Well, hello everyone, and welcome to this continuing professional development activity entitled No Public Health Without Mental Health, Integrating Mental Health into the Public Health System. And my name is Professor Brian P. Mangum, and I'm a consultant epidemiologist and also an assistant professor of epidemiology and biostatistics within the School of Public Health and Primary Care at Fiji National University, formerly Fiji School of Medicine. And I'm also an assistant professor of epidemiology and public health in the Public Health Training Program at the College of Micronesia, FSM. And the reason I'm bringing this to you today is that I have been brought from Fiji, which is where I normally call myself at home, to the beautiful northern Pacific, the USAPI, and I'm currently located in Pohnpei, in the Federated States of Micronesia. And I've been brought here on a grant between the University of Arizona Zuckerman College of Public Health and the Pacific Island Health Officers Association out of Hawaii to bring activities like this to the Pacific to help strengthen the medical, nursing, and public health access to continuous professional development courses such as this one. So let's just jump right in. What are we going to be talking about today? Well, as you know, we're going to be talking about mental illness as it relates to public health. And the first thing that we're going to talk about is how mental illness really underpins many of the key public health challenges that we face out there on a day-to-day basis, whether in public health or medical or nursing practice. Okay. And that's going to be things like a disproportionate burden of disease related to premature death from cancer, cardiovascular disease, smoking, long-term physical disabilities, alcohol and substance abuse, all of which can be associated back to having higher rates among our individuals who are mentally ill. So we're going to talk about that disproportionate burden and how public health programs that work to address the burden of public health are also going to be working to address the burden of the non-communicable diseases, which are quickly overcoming the region as well. And then we'll move on and we'll talk about how early interventions can reduce both the harm of mental illness, not only the direct harm of the mental illness, but its associated public health problems such as premature death, cardiovascular disease, and so on and so forth. But in so doing, because we're treating individuals here with chronic illnesses, we're going to reduce the economic and the social cost upon the islands where we work. That's going to lead us into a discussion about how can we tackle the social and the economic inequalities that lead to high rates of mental illness, because what you're going to see when we present some of the statistics is that individuals who are socioeconomically and otherwise disadvantaged, such as having lower levels of education, not making as much money, being in the poorer income brackets, and in particular children who come from homes where there's unemployment and lack of education, all predispose an individual to have a higher risk for mental illness. Okay. Now what we're going to see is that here in the Pacific, that even though traditionally, if we go back say 100 years or so, or even 120 some on years ago, that the burden of mental illness was actually quite low here in the Pacific. There's a wonderful book that deals with healthcare in Guam from the period of Spanish colonization all the way up into the mid-1990s and early into the 2000s. And there's a number of sections in that book that have good evidence to show that mental illness as well as non-communicable diseases really weren't a problem for the traditional societies that made up Micronesia and the USAPI. But with the introduction of colonialization and with the introduction of economic growth and development, then we see an increase both in non-communicable disease as well as an associated burden increasing in terms of mental illnesses such as schizophrenia, bipolar depression, postnatal depression, and so on and so forth. And so if we look at the islands as a whole and we see that economic development is ongoing here, many of the problems that we would associate with depression and mental illness on the mainland, okay, in other words, people are unemployed, they have economic stressors, they have the stress of work, they have the stress of family, and so on and so forth that comes from living in a developed society, we're actually going to start to see an impact of that out here. And the reason for that is that the USAPI is developing economically. That's why if you look at a Guam or a CNMI, which are more developed than, say, a Chuuk or a Koshrai or something like that, you're going to see that Guam and CNMI have a higher burden of both NCDs and mental illness as opposed to Guam, or as opposed to like the Chuk and the Koshrai and the Pohnpei and so forth. But as the Chuk and the Koshrai and the Majuro and the Palaus begin to develop economically and culturally, we're going to see that same burden of NCDs as well as mental illness begin to rise there as well. So we can't simply bury our head under the rocks and go, but we're a traditional society. We don't have problems with mental illness, because the evidence we have shows that we're seeing economic development and we're seeing increased rates of mental illness in the population out here. Okay, so we're going to talk about tackling social and economic inequalities to address that growing rate of mental illness in our populations. Okay, then I have a nice list of cost-effective interventions for public health that we'll go through, and these are things that have been shown to work elsewhere in low resource and high resource settings, and they are things that can be easily applied out here in the Pacific. We'll talk about political action. In other words, what can you do as public health planners, practitioners, medical practitioners who belong to societies like the Pacific Basin Medical Association or the Pacific Basin Public Health Association? How can you become better advocates for the populations that you serve that either have mental illness or at risk for mental illness with the politicians, with the key decision makers? So we'll talk about that. And then we'll talk about important policy changes that have been shown to have a positive effect on both reducing the rates of NCDs and the associated risk factors of mental illness that you as public health planners and developers can use in your practice as well. So an exciting presentation. I hope you're going to enjoy it. So let's just start out with this concept that mental illness underpins many of the key public health challenges that we face in the Pacific as well as throughout much of the world. Now, there's vast evidence to show that mental illness is associated with greater risk of physical illness, and physical illness in turn increases the risk of mental illness. So it's like you've got one following on another. Essentially, we've got a series of independent and dependent risk factors that reinforce one another. Okay, and then those risk factors in turn come into play when we look at the social determinants of mental illness. So in other words, lack of education, lack of economic opportunities, and so on and so forth that are causing many problems out here in the Pacific. So let's look at a couple of these. Well, we do have premature death. We do know from really good stats from worldwide that people with schizophrenia and bipolar disorder, really quick, if we were to just look at the diagnoses of mental illness across the USAPI, what we'll find is that we have depression usually is leading. And do keep in mind, depression is like the common cold and mental illness, okay? Tends to be the thing that we see quite a bit of, all right? It's something that can be effectively treated in outpatient settings if we have compliant patients and if we have the resources available. So in other words, if we have the ability to combine drugs with psychotherapy, okay? That's usually followed by either schizophrenia or bipolar in the number 2 and the number 3 slots, and those kind of vary. Some islands it's schizophrenia number 2, some islands it's bipolar number 3. But those are the major types of diagnoses that we see out here. And then of course we also see some of the personality disorders out here in the USAPI, such as antisocial personality disorder, and so on and so forth. But the real big ones are depression, like I said, the common cold mental illness, followed by either bipolar and then schizophrenia as well. Okay. All right. So getting back to this idea of premature death. So people with schizophrenia and bipolar disorder die on an average 20 years earlier than the general population. And the reason for that is largely owing to physical health problems that are associated with how they live. Individuals with schizophrenia, for those of you who are medical providers, or for those of you who are mental health nurses or even public health planners trying to get these individuals into care, you know that they're very difficult to treat. Okay. They're not always trusting of the system. They may be living in a homeless type of environment or moving from house to house. They have lack of access to care. Getting them to show up with appointments is extremely difficult. And of course, getting them to take their medication when they're living in an unstable environment is very difficult as well. Okay, so all of those are physical barriers that tend to lead into things like abuse of alcohol, improper diet, inability to care for themselves and access preventative services, and all of that leads to what? Well, it leads to that fact that we mentioned already, that they tend to die on average 20 years earlier than individuals in the general population. Okay? What about smoking? Well, people with mental disorders tend to smoke almost half of all the tobacco. Did you hear that? 50% of all of the tobacco consumed worldwide is consumed by individuals who are mentally ill. Mentally ill individuals also account for approximately 50% of all smoking-related deaths worldwide. So we know that tobacco, we know that lung cancer are significant problems, okay, and they are actually growing problems here in the USAPI. With the development of societies, with economic and political development like we've seen actively going on out here in the USAPI and the rest of the Pacific, we're also seeing an increasing rate of tobacco use. So with that, once again, okay, comes that double burden of disease. We've got individuals who are mentally ill, plus they're using tobacco, and that all results in a burden of disease that's difficult for society to bear in terms of the resources needed to treat these individuals appropriately. And just as a quick point of comparison, even though most of our islands are not going to actually have inpatient mental health units, I imagine CNMI and Guam probably, and maybe some of the other jurisdictions, but most of the time you're going to find your mentally ill patients are going to be housed in the general med surg wards. But if we look at inpatient mental health units, we find that we have a 70% tobacco usage rate on most inpatient units that are dedicated to mental illness, as opposed to 21% on inpatient units not dedicated to mental illness. So just once again reinforcing that fact that our mentally ill patients tend to have much higher rates of tobacco use. And one of the things that we'll talk about in our specific recommendations is about developing tobacco prevention and cessation programs that are made available to our mental health patients. Also, okay, so continuing this idea of mental illness underpinning many of our key public health challenges, we also can talk about death from cancer and heart disease. Now, we know that people with depression have a significantly worse survival rate from both cancer and from heart disease. Now, if we look at just specifically the social epidemiology of cardiovascular disease and myocardial infarctions, we know that individuals, okay, that are depressed are less likely to engage in behavioral change after they've had a myocardial infarct, after they've had a heart attack. So these individuals are less likely to adopt a healthy lifestyle, reduce their caloric intake, go to cardiac rehab, and things like that. Okay, so that's a significant reason why we're concerned about individuals with cardiovascular disease that are also depressed. Okay, and we also know that depression actually doubles the risk of heart disease. Now, there's a couple of different reasons for that, but that's still more associative evidence that we have, so we're not going to get into it at this point. But the point is that with these individuals that are depressed, we do see higher rates of heart disease, we do see higher rates of cardiovascular cancer, and we're also going to see lower rates of survival following heart attacks. Okay. Now, in terms of long-term physical conditions, this would be like anybody that has type 2 diabetes, cancer, and amputation, HIV, something along those lines. Okay, people with 2 or more long-term physical illnesses have a 7-fold greater risk of being depressed than individuals who do not. And it's easy to see why this is. Say you've got an individual that was diabetic and they end up having a BK amputation, a below-the-knee amputation. Suddenly they can't work and they can't take care of their family. They see themselves as worthless. They don't see themselves as actively participating in society, whereas maybe previous to the amputation they were very active physically and they took care of their family. And so it's not surprising that we see higher rates of depression in these patients. So for those of you who are public health planners and those of you who are practitioners of healthcare out there, please be aware of screening your chronic disease patients for depression. And if they're depressed, please try to get them to engage in appropriate treatment protocols. As I mentioned before, we know we have really good evidence to show that if we use like SSRIs, selective serotonin reuptake inhibitors, that if we can get patients to stay on those, then it tends to have a very good impact on the rates of depression. Now, of course, the catch-all to all of that is, well, you put somebody on an SSRI, they feel better, they go off the SSRI, the depression comes back, okay? And then the other element of that is you put somebody on an SSRI, how long do you keep them on it? Can you deal with the other psychosocial behavioral issues that actually cause the depression in the first place? And that's a question of resources resources out here in the Pacific? Do we always have access to the mental health professionals that we need to engage in these behaviors? And the answer is no. We do have an acute shortage of psychiatrists who are physicians that are trained to practice mental health care, and we also have an acute shortage of other types of mental health providers such as psychologists, mental health practitioners, social workers, psychiatric nurses, and so on and so forth. So those are all long-term things that have to be looked at. What about alcohol? Well, excessive consumption of alcohol is associated with higher levels of depressive as well as affective problems, as well as schizophrenia and personality disorders, and also with higher rates of suicide and self-harm. Okay, so that's something that we should be aware of, and we should be screening our patients in primary care settings to see if they have alcohol problems. We can use like the CAGE mnemonic to screen these individuals, and once we know we have someone that has an alcohol problem, then we should be concerned about that individual in terms of depressive symptomologies and possibly other comorbid mental health conditions as well. Now, I do want to point out that historically, public health strategies have really concentrated on physical health, and they've sometimes overlooked the importance of both mental illness and mental well-being. Now, I do want to differentiate those there, okay? Mental well-being, as you probably remember from the WHO Declaration on How We Define Health, is the complete absence of not only physical disability and disease, but a sense of well-being and mental health that allows us to engage fully in our lives, okay? Now, including mental health at the heart of public health agendas is a good way for us to improve people's lifestyles as well as reduce behaviors that tend to put people's health at risk. And thereby, what we can do is we can actually both prevent physical illness and we can reduce the overall burden of mental illness in the population as well. So this is one of these instances where we have a more bang for your buck approach. Okay, if we treat mental illness, then in turn we reduce the amount of tobacco that's consumed in a society. We reduce the alcohol consumption problems, and we reduce the social problems that come along with mental illness and substance abuse as well. You know, one of the key targets for a lot of our public health and mental health programs is simply keeping our schizophrenic patients out of jail. All right, making sure that they don't get in trouble in a society that doesn't understand mental illness with a patient who's not appropriately taking his medication, and so the patient ends up in jail. And so that's a significant issue that we need to consider once again, because we don't always have the resources out here to deal with these problems. So prevention becomes duly important. Now let's talk about this concept of the onset of mental illness, okay? And that's going to come with this idea of when is it most appropriate to develop interventions to prevent mental illness. Now, most mental illness begins before adulthood, and oftentimes it's going to continue on throughout the lifespan, all right? So it's a chronic condition. Now, half of all lifetime cases of diagnosable mental illness begin by age 14. So think about that. 50% of these individuals are going to be diagnosable by the time they turn 14. So what does that tell you about prevention? Well, it tells you prevention needs to become a very, very early thing in terms of the lifespan, okay? And by the mid-20s, we see that about 3/4 or about 75% of our mental illness diagnoses are actually going to have been made. Now, tackling mental health problems early in life is a significant challenge for public health programs. But if we can do it, it will improve educational attainment. So in other words, people will have higher educational attainment. It'll improve employment opportunities. Oftentimes that's associated with higher education as well. It's going to improve physical health because these are less likely to be individuals that have heart disease and smoke and have cancer and so on and so forth. Okay. It's going to reduce the level of substance abuse in our society. So alcohol abuse is going to go down. And in theory, I haven't seen any studies about this, but in theory, if the levels of alcohol abuse are going to go down with individuals that have in which we prevent mental illness, then the levels of the abuse of grog or kava or sakau, depending on what island you're on, whatever you want to call it, that is also going to go down as well. Of course, we're also going to be able to reduce issues with self-harm and suicide, and we're also going to have a better luck with family conflict and social deprivation. So we're not going to have so much of the problem with families getting into fistfights and families getting very upset with a patient who's not taking their medication and so on and so forth. So overall, what we can say about early intervention is that early intervention is going to increase life expectation. It's going to increase economic productivity. It's going to increase social functioning. And overall, it's going to increase the quality of life of the populations that we serve. And isn't that really the function of public health, to do all those things? All right. So by engaging in a discourse about how we can prevent mental illness in early adulthood, and even as early as age 14, then we're increasing the quality of life of the populations that we serve in public health. Now, early intervention can also have benefits across multiple generations. Now, promotion and prevention is also important in adulthood and also going to be important in the older years as well. So when we promote healthy workplaces, what we do is we reduce the stress, and then we reduce the anxiety and the risk of mental illness at work as well. Okay, intervening early in the illness of of individuals of older age, such as individuals that might be at risk for dementia or Alzheimer's, can actually lead to better health for people in later life and can lessen their dependence on health and social services later in life as well. And for those of you that are involved in public health planning and medical planning, you know that that's one of the extremes of the range where we see people using a large number of medical and social resources, or the elderly individuals. All right, so if we can reduce the burden of mental illness, depression, and so on and so forth in the elderly population, then we reduce that burden on the economic system as well to provide for these individuals. Now, it's also important that we focus on our really vulnerable groups in terms of prevention, and these would include people who are socially excluded or economically deprived, children who are in institutional care systems such as foster homes, individuals that are in prisons, because we do have prisons out here in the Pacific as well. Okay, all of these individuals are at higher risk of developing mental illness, and as such, we want to focus on prevention in these populations as well as interventions to ensure they're receiving the appropriate care. Okay, and I do want to mention, in terms of targeting specific populations, that we need to put a special focus on children, and in particular children coming from the poorest homes. All right, because kids that come from poor homes are 3 times more likely to be mentally ill than children that come from wealthy homes. Okay, and once again, I can hear you saying it out there, but we're the Pacific, and we take care of our own, and so on and so forth. But remember my discussion earlier, we are developing economically rapidly out here, and as we develop economically, we're seeing many of the problems that are traditionally associated with the mainland come to us. Just look at non-communicable diseases, all right? That's a wonderful example of how we've economically developed out here, and with that has come an over-reliance on imported foods and unhealthy foods and so on and so forth, okay? I'm going to give one of my plugs for one of my other lectures. If you go to my YouTube page, there's a lecture that deals with economic and nutritional shifting as the global roots of the NCD pandemic, and it talks a little bit about how global economic factors are resulting in higher rates of obesity and mental illness and so on and so forth at the local level. So if you'll go out and watch that, I'd highly encourage you to do that, and I can provide you a certificate of professional development for that as well. Okay, so like I told you in the introduction, one of the things that we can do is we can look at tackling social and economic inequalities. Now, this is a systems-based approach, okay? This is not just saying, how do we make sure our schizophrenics are getting their antipsychotic medication? This is looking at how do we create equality in a society so that everybody has access to educational and employment opportunities, which can reduce the incidence of mental illness and also associated factors like NCDs as well. So like I said, we've got this divide between the rich and the poor, okay? And this divide between the rich and the poor is actually growing here in the Pacific. We're seeing a growing middle class and a growing upper class, and with that we're also seeing a growing lower class, where people that live below what we might traditionally call the poverty line, okay? Now, this is largely due to the economic growth that's going to favor a very small percentage of the population here in the Pacific. Those who own certain economic resources have high levels of education and so on and so forth, okay? And so we have this inequality between the rich and the poor that continues to widen, Okay, and in fact, one of the things we know about this widening gap, income gap, I guess we could call it, is that those living in the poorest conditions on the earth tend to die about 7 years earlier than people living in the richest areas. We already know from some of our other continuous professional development activities that we have now become the most obese area of the world, with certain populations having obesity rates of upwards of 80%, and with that has come high rates of NCDs. So we're already seeing that we're dying considerably earlier from non-communicable diseases, lifestyle-based diseases, and then we take these individuals that have mental illness as well, and we get this double compounding burden. They both have NCDs and they have mental illness, and so they have significantly shortened lifespans. Okay, but just by and large, we do see that those living in poor conditions die about 7 years earlier than those living in better conditions. So in other words, inequality itself is a major determinant of mental illness. So the greater the level of inequality, the worse the health outcome of the individual. Now, greater income inequality is also linked to decreased rates of trust, as well as social interaction in the community, and then also increased hostility, violence, and racism, as well as lower levels of well-being. Okay, and all of those things in turn increase the risk of there being mental illness present in these populations. So in other words, there is a direct connection between economics or income inequality and the risk of mental illness as well. And that's something that we in public health, as well as the politicians, the economic development corporations that are so present out here in the Pacific, they should be aware of these things, and they should be working towards narrowing that income gap and finding ways to provide educational and employment opportunities to larger segments of the population. So what else can we say about this growing income gap here in the Pacific? Well, we can look at things like unemployment. All right, we know that we have high rates of unemployment, and we know that in certain areas of the Pacific we have a high remittance economy. In other words, people don't work. They rely on money that's being sent back from family members who are working overseas in areas like the United States, Australia, New Zealand, and so on and so forth. So parental unemployment is also going to be associated with a 2 to 3-fold greater risk of emotional or conduct disorders in children. So in other words, if we have parents that are unemployed, we have kids that are going to misbehave in school. All right, they're going to have disrespect for authority figures and so on and so forth. They might even be diagnosed with oppositional defiant disorder and so on. Okay. We also know that children from the poorest 20% of households are going to have a 3-fold greater risk of mental health problems than individuals that come from the richest 20% of households. Okay, we also know that this income inequality is going to affect the mental health of adults as well. So a possible prediction for the Pacific would be data that we see from elsewhere that shows that men living in the poorest households have almost 3 times the rate of mental disorders than those that come from the richest households. Now, poor mental health can have an impact on future generations as well. And, of course, we have what we refer to as the poverty cycle. So, in other words, those with mental illness are less likely to have good educational and employment attainment. They live in poverty, and they tend to pass on that lower educational attainment to their children, who perpetuate that poverty cycle. Okay. So in other words, what we're left with is we're left in a situation where we need to develop policies to put into place to address the social and economic inequalities which directly contribute to the poor mental health and well-being of the populations that we have here in the Pacific. So what are some cost-effective interventions that we can look at? And I do want to point out that these are interventions that have been proven, so this is evidence-based, and they have been utilized in both high-resource and low-resource settings. Okay. And so I just want to point out that preventing even a small percentage of mental and substance abuse problems will actually improve the quality of life for individuals, families, as well as communities across the Pacific. As such, it's important to keep in mind that prevention and promotion activities need to be part of a strategic, sustainable population-based approach which will reduce the burden and cost of mental illness, as well as promote well-being and reduced inequalities across our jurisdictions here in the Pacific as well. And in particular, do keep in mind that a number of studies have demonstrated significant cost benefits from early year interventions, so interventions before the onset of most most mental illnesses, so before about the age of 14 to 20, okay? And that these early interventions tend to have long-term outcomes. So in other words, if we can prevent mental illness in early age, then it's less likely that the individual will develop a mental illness later in life, okay? And what does this do? Well, this results in significant economic as well as social savings. It reduces the amount of welfare and criminal justice costs, as well as results in higher income earnings for these individuals across the lifespan as well, since they're not impacted by the high burden of mental illness. So let's get into some of the specifics here of some of these evidence-based, cost-effective interventions. Well, the first one we can look at is parenting programs, and in particular parenting programs for individuals with children who have conduct disorders, such as oppositional defiant disorders. So in other words, teaching parents how to deal with difficult children. This can be extended to teaching teachers, caregivers, members of the community as well, how to deal with these difficult children as well, to prevent oppositional defiance disorder from becoming some of the really bad personality disorders that can develop as well. We also have health visitor programs. Health visitor programs are interventions for people who are at risk, okay? And one example of that that is particularly effective and should be considered here in the Pacific is for ensuring women that are at risk for postnatal depression are appropriately screened by their provider. So one of the things that we know is that even though a significant percentage of the population will suffer from postnatal depression and that it can be treated, all right, is that OB-GYNs, midwives, and those that provide antenatal care, they don't speak with their patients about it. So their patients don't know that the potential exists for the depression to happen. Then they have the baby, they feel sad about the baby. They don't understand why everybody around them is so happy about the baby, and they feel depressed in a society that puts a high amount of emotional connection on bringing a new child into the world and making that child part of the community. So we need to make sure that we educate women that postnatal depression can happen. It's also known as postpartum depression. I apologize. I keep using the British nomenclature. For those of you trained in the U.S. system, you probably know it as postpartum depression. Okay. Anyway, but the point is, if we train women to understand that postpartum depression is a possibility, and we train communities to remove the stigma of postpartum depression, then these women are more likely to seek care from their providers. And this should include health visitors that come around and ensure that women are not suffering from it, and if they are, they're getting the appropriate treatment that they need. Then we can also engage in school-based programs, and these would be things like programs that reduce violence in our schools, reduce the risk of bullying, okay, and so on and so forth. And by doing that, it result in better scholastic performance. A kid that feels good about himself and is engaged in school and doesn't feel frightened at school and can perform well in school is more likely to have a better scholastic performance, resulting in better economic performance later in life, both of which are going to reduce the risk of mental illness. And then we also want to engage in what we call screening and brief interventions. So in other words, we want to identify people who have an alcohol problem or a substance abuse problem or a kava or grog problem, and we want to provide them some form of treatment, and that can be what we call brief interventions in an inpatient setting followed by outpatient follow-up. Okay, but all of this presupposes what? This presupposes that we've got an integrated system of public health and medical health. So in other words, our clinical providers and our public health providers are working close together to implement these programs. And in many ways, we're actually lucky here in the Pacific because I see better integration of our hospital and our outpatient services with our public health services than sometimes we see on the mainland. All right, so continuing our discussion of some of these cost-effective interventions, and like I said, these have high economic return. In other words, we've looked at these in terms of a cost-benefit analysis. In other words, it's cheaper for us to it's cheaper for us to prevent the problem than it is for us to actually treat the problem. And one of the reasons for that here in the Pacific Basin, as you know, and I've mentioned previously in the lecture, is we don't have a lot of psychiatrists, we don't have a lot of psychologists, psychiatric nurse practitioners, and so on and so forth. So for us, it truly, truly is better in terms of long-term cost to both society and our pocketbooks if we just prevent the diseases from happening. Okay, so we can also look at well-being promotion. We can look at programs to make our workplaces more pleasant, okay, to make our homes more pleasant. We can implement interventions in churches, in schools, and so on and so forth, all with helping people live mentally happy, mentally active lives. Because when we're mentally happy and mentally active, the risk of depression, the risk of bipolar, and so on and so forth goes down. Okay, and I'm not saying we're going to be able to prevent all cases of schizophrenia and depression by simply having wellness programs and making sure people exercise enough and feel good about themselves, but it can have an impact on those rates, okay? What about early detection programs? Well, let's educate the public about the signs of mental illness. Let's educate our nurses, our public health practitioners, our maternal and child health practitioners, our physicians. We want people to recognize the warning signs of depression because, like many, many other illnesses, the earlier we intervene and the earlier we get people access to resources, the better the outcome for these individuals. And in particular, we want to focus on early detection of individuals who are at risk for suicide. Suicide rates across the US API are going up, and so that's something that we need to be concerned about and detecting early on. And as you know, usually what we see is we see that there will be an initial attempt at suicide, okay, and oftentimes that's associated with a cry for assistance. Hey, look at me, I need help. I know of no other way to cry for help than to make an attempt on my life. And then for those individuals that attempt but don't complete suicide, if we don't get them the assistance that we need, we have good statistics that show those are individuals who go on and they actually complete the act of suicide. And that's their final act of desperation. I didn't get help when I cried for help. Now I see no other choice but to actually end my life. Okay, so we want early detection, and once again, we want to remove the stigma associated with mental illness as well. Supportive employment settings, those who are recovering from a mental illness, we want to work with employers to ensure that these individuals can actually have a job and contribute productively to society. I've only mentioned this briefly a couple of times, but do keep in mind that we want to provide older adults, okay, people that are maybe retired or getting older in life, we want to provide them with physical and mental activities to reduce the risk of things like dementia and Alzheimer's, which is the most common form of dementia. And at the same time, we want to reduce the risk of hypertension, hypercholesterolemia, and so on and so forth, because that in and of itself actually reduces the risk of dementia, senile dementia, as well as Alzheimer's, stroke, and so forth. So we want our older populations to remain physically active as well. Okay, and of course I've mentioned this a couple of times. Let's educate the communities about what what mental illness is. Okay, people don't choose to be schizophrenic. Nobody wakes up one day and looks around and goes, "Hey, today I think I'll be a disorganized schizophrenic." Nobody does that. Nobody wakes up and looks at their life and goes, "Wow, I've got great kids. I've got a great job. I love my family. I go to church, but I'm going to be depressed." Okay, oftentimes these are things that are beyond the control of the individual, and so we need to help society understand that these people didn't make this choice oftentimes, okay, and that there are treatments available, that these individuals are not strange. I mean, think about it, you guys. If I go to the doctor and he diagnoses me with hypertension, I'll probably go home and I'll tell my wife, I can't believe it, I have high blood pressure. The doctor put me on ACE inhibitors and says I need to lose weight. Okay? Or I might go to work the next day and go, wow, Paul, can you believe what's happened to me? I'm hypertensive. But if I go to the doctor and he diagnoses me with a mental illness, man, my lips get locked. I don't talk about that with anybody, and that's because there's stigma, and that stigma can stand in the way of people actually accessing services and getting the help that they need. And public health is well designed to provide educational programs based upon things like reducing stigma. So get out there and do it. Okay, well, I do want to mention that think about a lot of the things I've suggested. A lot of the things I've suggested are going to require political action on the part of policy makers, and they're going to require policy changes as well, which we'll talk about in the next slide. But public health agencies really need to become advocates for the mental health patients that they have in their practice, okay? And I can hear many of you out there right now saying, oh, but we're government employees, we can't advocate, blah, 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 okay? We can't go march up to the legislature and demand that they make changes. Okay, well, that's why you have organizations like the Pacific Basin Public Health Association, the Pacific Basin Medical Association, the APNLC, and so on and so forth. Okay, these are non-governmental organizations that you can belong to that can advocate for for the people that you serve. Okay, and you can advocate as well. You can write reports. You can conduct surveys. You can undertake studies, all right, to show the magnitude of the problem, all right? And then from those studies, you can make recommendations on changes that need to be made at the political level. So in other words, there are many ways in which you can place mental health issues prominently in front of government so that they adopt certain strategies to reduce the burden of mental illness. The other thing that you need to do is you need to make them aware that mental illness is directly connected with NCDs, okay? NCDs are the crisis of the time. It's the overwhelming tsunami that is slowly drowning the Pacific, and we all admit that. But what have we seen in this presentation? We've seen in this presentation that there's a connection between NCDs and mental illness. So we reduce mental illness, we reduce the burden of NCDs. Remember, 50% of the individuals in the population that are using tobacco are mental health patients. Okay, that alone should be enough for the political decision makers to take action. So make them aware of what these cost-effective interventions are and how that there is a significant cost-benefit analysis associated with reducing the burden of mental illness in the population. And of course, what about you at the level of the individual that's running a public health agency or the public health planner, or you're running a program such as the diabetes program or the mental health program or something like that, okay? What are policy level changes in your organization that you can undertake, okay, that you can promote? Well, one of them is you can put minimum alcohol pricing policies into place in your community. In other words, don't sell alcohol too cheap. If the people with mental illness are also most likely to not have employment opportunities, then they probably cannot afford alcohol unless the alcohol is being sold very cheaply. So there have been a number of studies that looked at these minimum alcohol pricing policies, and they reduce alcohol consumption in the population as a whole, but in particular among those with mental illness. Okay. We also want to promote programs that reduce inequality for women and children. Okay. Remember, children are particularly at risk, and women tend to have higher rates of depression than do men. Okay. Women also tend to have higher rates of attempted suicide than do men. Men have higher rates of completed suicide, though. Okay. Speaking of suicide, we want to ensure that suicide prevention remains forefront in our policies. How do we reduce the stigma associated with depression and suicide? So you think about suicide and depression, they almost always come together. Once again, nobody wakes up on a Monday morning, has had a nice weekend with the family and goes, oh, today's the day I'm going to overdose on drugs and kill myself, okay? It's usually a cycle that builds along, and it almost always associates with depression and sometimes substance abuse as well, okay? Smoking cessation and prevention programs for the mentally ill. We already talked about that, how 50% of our smokers are also the mentally ill patients that we're dealing with as well. So we want to provide them with the ability to quit as well. Addressing stigma, we've already talked about that quite a bit already. Targeting high-risk groups such as children in foster care, prisoners, so on and so forth. Those should be the targets of our interventions as well. And then we want to promote well-being in old age to prevent senile dementia, Alzheimer's, and so on and so forth. And then also have a focus on maternal well-being. Remember, we talked about making sure people have access to antenatal care, making sure that they have screening, and that they understand postpartum depression, postnatal depression, and that they understand that that is normal and it can be treated if they will access the care system. And that also has a lot to do with stigma as well. Congratulations, you did it. You made it through another one of my continuous professional development activities. Yay! Okay. And as always, I just want to say thank you, thank you, thank you. Vanaka Vakalevu, Kalangan, Mashadanki, whatever language you happen to speak out there, thank you for listening. And as always, thank you for the wonderful hard work that you're doing every day. Whether you're directly in public health agency, or maybe you work for an NGO, or maybe you're a physician, a nurse, maybe you're an administrator, whatever you're doing something good out there, and you're helping to make the Pacific a healthier place, and I thank you for your efforts. Now, as always, you can see that lovely certificate of continuing professional development on the screen there. Suitable for framing. I think it's gorgeous. I personally designed it. Okay. If you will send me an email to brian.mangum@fnu.ac.fj, I am happy to send you one of these beautiful suitable for framing CPDs, all nicely signed by me. You can use it for a variety of purposes. Use it for continuing medical education, continuing nursing credits. Use it with your local HR department, however you want to use it. But it's my way of saying thank you for listening, and I hope it's something that you can put to use. And as always, thank you, and have a wonderful day.